started because I don't want to forget. I do want to put a plug in for our regulatory and ethics consult service. Many of you probably know our amazing regulatory specialists, Rachel Olick and Allison Santiago. They are, part of the amazing navigator team, service team of CCTS, and they are available and willing and able to answer all of your regulatory and ethics questions as you are submitting to the IRB. So I don't want to forget to put in a plug for that, as hopefully this talk will stimulate for you lots of questions about your own research, maybe things that you've always wondered, or questions about upcoming submissions that you have. So I definitely want people to take advantage of our services. Okay, so what am I going to talk about today when I talk about where methods and ethics meet? Where are we meeting and what are we talking about? I'm going to start by reviewing some of my assumptions about the relationship between methods and design and ethics, and why the IRB submission and review process can be challenging for certain designs and methods. I want to start there just to set the stage for then talking about a couple different research methods that are common in clinical and translational research that pose what I would call unresolved ethical and regulatory concerns, despite being mostly low risk. So I'm going to focus on pragmatic clinical trials and dissemination and implementation studies. These are design methods that are used frequently in clinical and translational research, encompass a lot of different kinds of approaches and implementation and data collection strategies. I'll talk more about them in detail when we get there. So if you see these terms all the time and you wonder what they mean, don't worry, I will talk about what these kinds of studies involve. And then I want to review considerations for addressing some of these unresolved issues and make your research development and implementation go a little bit more smoothly, hopefully. So like I said, first I want to start with some assumptions about the relationship between design methods and ethics. And this is really just sort of the way I think about the way I think about the development of protocols, the submission of protocols to the IRB, and the review and approval of those, and ultimately implementation of research. First, I think it's worth saying the obvious is that poor design equals unethical research. A poorly designed study can't answer the question it aims to study. If the question can't be answered, there's no possibility of social or scientific benefit. All research poses some risk. At minimum, there's a risk of harm from breach of confidentiality or burden of time that could have been spent doing something else. If we expose participants to risk or burden without any potential for benefit, this violates the principle of beneficence, and therefore a poorly designed study is unethical and humans should not be asked to participate. So I really think about ethics and methods as going hand in hand, but we often, as researchers, think of them separately. And this is maybe because we're trained this way, right? Someone comes in at the last day of our methods class and talks about IRB submission. Or if you think about an NIH application, I think it's very strange that there's a human subjects consideration section that's sort of separate from the main body of the application. So there are these things that, as much as they're tied together for me, there are these sort of ways in which the separation is reinforced. And so part of what I want to do here is just like lay that out at the beginning and get us thinking about and really embracing this idea that methods and you can't think about methods without ethics. You can't think about ethics without methods. Different research methods and designs raise different ethical and regulatory concerns, but different types of research and different types of researchers share many of the same challenges in answering these questions, right? We all have to follow the Belmont principles. We all have to adhere to our federal regulations at 45 CFR 46 and our FDA regulations. I've noticed throughout my years conducting research, sitting on IRBs, consulting with researchers, that sometimes researchers think that their method or their design or their population is uniquely challenging. And I'm here to tell you that this isn't really the case, except for with very few exceptions. Maybe you're working with prisoners, maybe you're doing high-risk maternal fetal surgery. But answering all of these questions is necessary to developing a protocol and submitting to the IRB. And researchers working in lots of different designs, different approaches with different populations have challenges. Nobody is, nobody's design raises red flags. Everyone is given, we all face more shared challenges than we face different challenges. For all the challenges of submitting to the IRB and responding to requests for more information or changes or asked to justify certain decisions, ethical issues and concerns can almost always be resolved, right? Most proposed research studies are approvable, but sometimes we need a change in exclusion criteria to minimize risk. Sometimes we need a change in the recruitment plan or approach to protect privacy, or to protect participants, protect their voluntariness, protect them from undue influence. Or maybe we need a change to ensure equity and fair subject selection. Sometimes we need a methodological compromise to minimize physical or social risk. Sometimes we need an extra safeguard to ensure comprehension or voluntariness, maybe a consent advocate or something like that. So I think it's important to acknowledge that usually there's a way to do the research that you want to do. Very rarely does a researcher never be able to get their study off of the ground because they can't get it approved by the IRB. I think that there's always a way to answer every research question ethically. I think that when IRB review takes a really long time or is very challenging with a lot of back and forth communication, it's not necessarily because that intervention is inherently dangerous or because the research involves something ethically dubious. It's often because there's an ethical concern that different parties have that people are struggling to clearly identify and articulate. And you have to be able to identify and articulate the concern before you can get to the solution. So that's part of what I want to focus on today, is sort of teasing apart what are we really concerned about here and how do we get from problem identification to solution? Because this can be a struggle, even when what we're talking about is fairly low risk research. There's often limited literature or limited guidance or limited consensus on the appropriate way forward. This might be the reason for challenges. And this is, I think, the case I know the case in when it comes to pragmatic clinical trials and dissemination and implementation research. And the challenge is that when there's limited guidance or limited scholarship around ethics and regulatory issues for a particular type of design or approach, like there is with pragmatic clinical trials and dissemination and implementation research, this can lead to variability in practice, right? IRBs have a lot of discretion and they make a lot of different decisions about what you can and cannot do and how you do it. And this creates confusion among researchers, even when they do the same kinds of studies at the same institution. And so I want to just sort of lay this out there as the environment in which we are working and trying to get our studies approved. And I think that when certain researchers that use certain designs or approaches struggle, it's because there are gaps in our existing ethical and regulatory framework. And I would say that sometimes the reason that we see challenges in IRB submission and review for minimal risk research, and a lot of pragmatic clinical trials and D&I research are minimal risk, it's because our ethical and regulatory framework was developed with the gold standard randomized controlled trial in mind. Lots of different researchers that use different methods and designs. I think of qualitative researchers who sometimes feel that they are scrutinized more than researchers doing, phase 2 clinical trials of drugs that have really significant side effects. But lots of researchers that use different methods and designs sort of feel the sting of what I often just refer to as the square peg round hole problem, or round peg square hole problem, depending on which one you prefer. The framework was really set up for evaluation of research that is testing new interventions, that involves randomization, that involves true uncertainty about which of those things work. And now we're in a different world, right? We're trying to figure out how we get things that we know work in controlled conditions into clinical practice. And that creates a new set of challenges, but we're still sort of operating in this old framework. And these designs can raise some really tough questions, right? Is it research? Who's a subject? Who needs to provide informed consent? These are really basic questions, but researchers doing pragmatic clinical trials and dissemination and implementation research, and ethicists like me who are trying to help them address these challenges, and IRBs like the ones I sit on that review this research, we all sort of struggle with some of these questions. And so I wanted to really talk about this today because it's so important to the work that we do as part of CCTS and at the Cancer Center, and where a lot of research is headed. We know that things work in ideal conditions. How do we close that gap from bench to bedside? I think here's the rub, and this is why these types of studies are interesting to me, right? The pragmatic clinical trials and D&I research are very low risk. And I think what makes them so challenging is that this is research that's embedded in the healthcare system, right? And so there are a lot of different people involved, a lot of uncontrollable variables. But the reality is that most randomized controlled trials, they're testing treatments with unknown safety and efficacy data, or your classic randomized controlled trial, I should say, not most, but sort of the classic randomized controlled trial. It's greater than minimal risk research, right? Randomization means that one group always fares better than the other. There are unknown risks. They're controlled conditions, but they don't tell us about everything that matters about an intervention or explain why some groups or individuals benefit more than others. And many years, we know, lapse between publication of RCT results and changes in standard practice. And so pragmatic clinical trials and D&I research has emerged so that we can test treatments, so we can generate data to support real-world decisions. And so pragmatic clinical trials are usually testing treatments with data from randomized controlled trials. So we know the safety and benefit profile of what we're testing. We're testing things that are usually FDA approved and comparing them against each other. This is usually posing minimal risk to participants. In dissemination and implementation research, we're aiming to increase the uptake and spread of interventions that we know are helpful, that have an evidence base. So arguably, not only is this research minimal risk, several people have made the argument that it's ethically mandatory, right? If we know that something works, we should be putting resources as a society into trying to make sure that that intervention reaches as many pieces of people as possible. There's a growing investment in these kinds of studies, but I was really shocked at the limited ethical scholarship and specific guidance for responsible conduct of PCTs and D&I research. So just to summarize the sort of backdrop and my assumptions before I get into the ethical issues of these specific designs, it's not that these designs and approaches raise ethical and regulatory issues that are unique. It's that they raise ethical and regulatory issues that are still unresolved. And they're not particularly risky. They just raise some new questions that our guidance doesn't still address in a really robust way. So I'm going to start now sort of transitioning to the meat here, to reviewing some of the ethical considerations for these types of studies. So I'm going to start with pragmatic clinical trials, or PCTs. The definition of a pragmatic clinical trial, and this is, sort of an umbrella term for trials that use a lot of different kinds of designs. A pragmatic clinical trial aims to evaluate the effectiveness of healthcare interventions in the real world in routine settings, rather than efficacy in highly controlled ideal environments like we see in an RCT. PCTs are designed for the primary purpose of informing decision makers, both practitioners, healthcare providers, and policymakers, regarding the comparative balance of benefits, burdens, and risks of a health intervention at the individual or population level. So we have lots of different treatments for a particular disease. Most of them have been studied in randomized controlled trials, maybe against a placebo, more likely against another standard treatment, but we don't really have evidence that compares these head to head. You hear that term a lot. That helps physicians or payers decide what should be what is important to making a decision about what treatment is right for particular individuals. So key features of PCTs, and this is what makes them ethically complicated, even if not, ethically suspect. They're in real world settings. The interventions are delivered by real world providers rather than specialized researchers. There's a lot of flexibility, so there's allowance for variations in treatment delivery that occurs in normal practice. There's really large sample sizes, which comes into play when we talk about informed consent and the possibility of waiving informed consent. There's hopefully a more diverse range of patients, including those that have comorbidities that would have excluded them from participation in randomized controlled trials, which ideally means we have more generalizable results, but we have to think about how to make sure that that happens. PCTs leverage existing infrastructure, primarily the electronic health record, for data collection and ideally lowering the costs of a study. And their outcomes are usually focused on things like quality of life, functional status, things that are important to patients, or what we call patient-centered outcomes, rather than specific biological markers or surrogate endpoints like we use in randomized clinical trials. So they're looking more at what's important to patients rather than biological markers that help us figure out whether something works or not really, really quickly. There are a lot of specific types of designs and approaches that fall under this umbrella of pragmatic clinical trials, and this language is constantly evolving. And even as I was reading about all of this, I was still trying to still learning new terms, and so again, there's a lot of overlap between these types of methods, and there's also overlap between PCTs and dissemination and implementation approaches. But you might have heard about comparative effectiveness research, which compares two or more interventions or strategies that are currently in use, approved strategies that are currently in use to determine which work best for certain patients or under certain circumstances. These are those, like, again, that head-to-head comparison, and a lot of the research that's funded by PCORI, the Patient-Centered Outcomes Research Institute. Cluster randomized trials, which is a design in which pre-existing groups or populations, such as people seen by a certain provider or people seen at a certain clinic or hospital, are randomized rather than individuals to receive different interventions. So very different from what we see in randomized control trials, where it's individual patients are randomized. Rapidly conducted observational studies. These are often used to understand natural exposures and outcomes in emergency situations in which real world data is gathered without introducing any intervention or environmental manipulation. Uses a lot of the same designs as a lot of epidemiology studies, case control, things like that. No intervention, just to get a rapid sense of exposure and outcome in real world settings. And often we see step wedge designs being used both in D&I research and in pragmatic clinical trials, in which clusters are randomized, everybody starts in the control condition, and they cross over to the intervention condition on a staggered schedule, meaning that all groups receive the intervention before the real end of the trial. And kind of a punchline here is that stepped wedge designs are often a solution to some of our ethical concerns about making sure that everybody who is involved in a research study, in a pragmatic clinical trial or in a D&I study, get access to an intervention that we know works. And you might have heard of some of these national initiatives. Again, the PCORI has their Patient-Centered Outcomes Research Network. NIH has what's now called its Pragmatic Clinical Trials Collaboratory, which was formerly called the Healthcare Systems Research Collaboratory. Again, as the language around these different kinds of designs evolve. But the rethinkingclinicaltrials.org is probably the best resource on guidance that has guidance for researchers both on design and ethical and regulatory issues, as well as dissemination of a lot of their findings. So I wanted to make sure to mention that. So there are several different what I might call buckets of ethical and regulatory considerations for pragmatic clinical trials. I'm going to review each of these in a little more depth, but there are specific considerations regarding who has authority, responsibility, and oversight, who are the participants, how do we assure representativeness and inclusion of diverse participants to promote generalizability, what are the risks of the research and how should they be minimized, and is it always necessary, or when is it necessary or not, to obtain informed consent for participants? And if we don't obtain informed consent, what else should be done to demonstrate respect for those participants? So, like I said, I'm going to go into a little bit of high-level detail regarding each of these considerations, just to get you thinking about what's unique about pragmatic clinical trials. So I think what's interesting about research that takes place in real-world settings is there are other people besides the researcher, the funder, and the IRB who get to decide if a site will participate in that research, right? We have health systems administrators and other institutional gatekeepers, we might call them, who might not want the burden of a study in their system, and they may not want researchers collecting data that might expose weaknesses in their system. And so this is a challenge for researchers when they want to try to engage representative sites. Maybe they want to do research in their own institution, but they need the go-ahead or okay or collaboration or the endorsement of leadership. This is something that research might be new to researchers who are used to engaging in other different kinds of research. They might not need the buy-in because usually these interventions occur on a system-wide level. When data are being collected from the electronic medical record and lots of different types of data are being fed in to address the impact of interventions that are tested in pragmatic clinical trials, there's a concern about collateral findings. How are they going to be addressed and by who? So for example, I've heard different researchers talk about their studies incidentally discovering that there are major deviations from standard of care in certain settings that are tangentially related to the research question, but this data is showing up because they're collecting other related data. Whose responsibility it is to address this? For example, if you find out that, hundreds of patients have had a particular condition undiagnosed due to, lack of awareness or training or something in the providers at that system. What if you find out something that you don't want to know? We often think about this, for example, in public health research when we're going into people's homes or when we do qualitative research and people don't necessarily only answer the questions that we ask, right? We think about what are we going to do if I learn something that wasn't part of my research? Well, this is, again, something that could and should be anticipated in pragmatic clinical trials. There is a lot of overlap between quality improvement and pragmatic clinical trials. And some of, there's cluster randomization, there's interventions directed at clinicians, there's secondary use of electronic health record data. There is implementation in the healthcare environment. So, if it looks like a duck and quacks like a duck, is it a duck? What makes researchers sometimes are tempted to turn a research project into a quality improvement project, because at many institutions, quality improvement does not require IRB oversight. And I don't want to get into this too much, but I just want to mention and caution against trying to change things to make something not human subjects research, because you think that's going to save you the time or the effort of IRB review and approval. Bad idea. Every activity, whether it's CARE or QI or a pragmatic clinical trial or a randomized controlled trial, all of these activities have ethical implications and have impacts on the people who are involved. It's better to have oversight and input than to go rogue. And usually QI, in my view, QI should have some other kind of oversight. So it's not that you're just now allowed to do whatever you want because you've determined or made the case that what you're doing isn't human subjects research. So I really think that's a bad road to go down. I think I'm very pro IRB. I'm very pro thinking of the IRB as not just a necessary step that we have to go through for compliance, but as a partner in making our research better. So anybody who knows me probably has already heard me say that a few times, but I really want to sort of caution against trying to change things just to make something not human research, thinking that you're saving yourself burden, or that you are somehow able to do things in a different way. You're really losing a potential protection and probably weakening the strength of your findings. What can be really confusing and frustrating for researchers is that, pragmatic clinical trials, their data is best when they are conducted with a large number of patients across a large number of diverse healthcare settings, which means that there are multiple sites involved. Options for oversight include central IRBs, depending on if something is subject to a single IRB mandate. There's also reciprocity agreements and shared review. All of these things are options, but local institutional acceptance of these different models for reviewing research, that multi-site research, local institutional acceptance varies, and it can be very confusing before you even get to assessing the risks and benefits of a study or thinking about consent and whether or not it can be waived. It can be very confusing to figure out which IRBs have oversight and how that's going to work. And so I have always viewed the OPRS, the IRBs at UIC to be very approachable. And these, if you have something on the horizon that's a multi-site study, I really recommend getting in touch with them sooner than later to try to figure this out, because this can be one of the biggest challenges, and it doesn't really have anything to do, again, with like risks to participants. And I just want to mention briefly that FDA, some pragmatic clinical trials might fall under the FDA regulations. If research is even if research is examining off-label use of an improved product, but the data collected are not going to be are not going to be used to support a new indication, then FDA regs will not apply. But this is always an important thing to figure out before you get started. You don't want to go through your whole IRB submission and then find out that you needed some kind of IND ID, some kind of approval from FDA. What's also important to realize, because of the large number of subjects involved in pragmatic clinical trials and often a strong case for waiving consent, if research falls under the FDA regs, then written consent is usually required, except in very specific circumstances. I think this is, again, kind of second bucket of considerations. Who are the research participants? That's another thing that sort of differentiates PCTs from RCTs. Direct participants are individuals who are being directly intervened upon and or from whom personal identifiable data are being collected for the purposes of the trial. But what's interesting about pragmatic clinical trials is often data are collected from individuals who are maybe not the target of the intervention. So in many PCTs, the intervention is aimed at changing provider behavior, but the outcomes are measured at the level of patients. Provider participants might face professional risks and have unique privacy concerns if their practice patterns are being studied. This also raises questions about consent, information, and transparency when you have data being collected through the electronic medical record about patients in order to determine whether or not an intervention worked, but those patients never really experience any sort of quote unquote research interaction. And this is why this issue of consent and waiving consent is so important. A lot of people who talk about the ethics of PCTs often use this term indirect participants, individuals, which just means that there are people in the healthcare environment who might be affected by the intervention because they work in that environment. Different kinds of staff, visitors, they might experience some element of the research, even though they're not, they don't meet that criteria of being directly intervened upon or having data collected from them. So there's just a lot more people involved in the process. I think, it's tempting to say that PCTs are always more representative because they have larger samples and simplified protocols. Not as, they don't have usually in inclusion, exclusion criteria, but this doesn't automatically make them more representative. I think it's important to think about the ways in which PCTs might actually reinforce existing inequalities in healthcare, and this really comes down to site selection, right? So number one, if you're doing research on routine care, we know in this country that not everybody's receiving routine care, right? Not everybody has a medical home, not everybody's seeing their provider, their primary care provider regularly. So we're still missing people, no matter what a good job we do in our site selection. We also, we want to do more research in community sites. We don't want to just be doing research in controlled conditions at academic medical centers. That's often why it's one of the big reasons why we have this gap, right? Between the results from a clinical trial approval and then having an intervention become standard practice. But community sites might not have the necessary infrastructure, and providers may be overburdened. So it might just be challenging, and it might require more effort and resources to include community sites in PCTs, but it's important to make sure that we do not reinforce existing inequalities in healthcare. And so really ensuring equity requires thoughtful, deliberate site selection, outreach specifically to medically underserved populations, and really importantly, investment in infrastructure at sites to ensure research readiness, and engagement of patient and community perspectives can help with all of this. But I really think it's that investment in infrastructure, and anybody who's been involved in starting up projects at community sites, I think really understands what I'm talking about. If we want to really engage the full range of populations in our research, we have to be willing to invest in the infrastructure and support sites so that they can be ready to participate in research. Risk determination and minimization. This is one of the most complicated aspects of PCTs. Anybody who has submitted an IRB application or reviewed an IRB application knows that this regulatory definition of minimal risk research is not very straightforward. In all research, there is disagreement about whether risk should be judged relative to the everyday risks that a healthy person is exposed to, or the everyday risks that a person who has the condition under study generally faces. In pragmatic clinical trials, there's ongoing disagreement about how we assess and inform participants about the risks of approved interventions, because just because an intervention is approved doesn't mean that it carries any more. Doesn't mean that it's not risky, but in a pragmatic clinical trial, it's usually the case that there was some chance that the person, the patient from whom data is being collected, might have received that intervention just by chance from their healthcare provider. Different kinds of interventions raise different concerns about risk, right? Some interventions in PCTs are directed at clinicians and systems, but yet they still expose patients to risk. And, our usual way of monitoring with the goal of minimizing risk, can't be applied, right? So usually we rely on data safety monitoring to let us know at a certain point in the trial whether we should stop or continue. PCTs often, because they're collecting routine clinical data, they just have an endpoint for the end of the trial and don't necessarily propose to do any interim data review, but this is something that maybe needs to be changed, and there needs to be creative ways to take the peak like we do in randomized controlled trials. Last issue I want to raise is informed consent. Individual written informed consent might be impracticable. This is one of my favorite words that I think only appears in 45 CFR 46. It might, I have a typo there, due to, should be DUE. Individual written informed consent might be impracticable due to sample size and or limited interaction with participants. There's an argument that individual written informed consent is often logistically burdensome and resource intensive. It might lead to selection bias, and also it might not actually provide any protection. I think it's another argument. We know that federal regulations allow an IRB to approve a waiver or alteration of informed consent when the research involves no more than minimal risk, when the research could not be practicably carried out without the waiver or alteration, and the waiver or alteration will not adversely affect subjects' rights and welfare. So if everybody with hypertension, if 10 sites are randomized and at 5 of those sites, everybody with hypertension gets one intervention, and at the other sites they get another one, and you have thousands and thousands of participants, and both of those treatments are approved, FDA approved, you have a good case that you can get a waiver of informed consent. But then what do? I think we spend a lot of time as researchers thinking about whether we can waive written informed consent, or whether we can alter informed consent, but we don't think about like, well, what else do we do if we waive it, right? There are different options we can offer. We could do opt-out, so everyone is notified, but unless they sign that they don't want to participate, they're in. We can do a shorter version of consent where we explain what we're doing very simply without having a 10-page form. Maybe we have a paragraph or just a verbal agreement, or we just notify people and we don't give them an option. And I think this is really something worth thinking about in a lot of different research situations, where even when we have, even when we meet the regulatory criteria for a waiver, there's often good ethical reasons for notification, right? It just provides some transparency. We are doing research here. We are trying to improve your care. We are using your data to improve your care and the care of future patients. I think these are good things that we want to tell people about, but we sort of have this this all or nothing, right? Either full signed informed consent, hitting all the different elements that are in 45 CFR 46, or just waive it and forget about it. And we don't really know a lot about patient attitudes and how patients feel about notification versus being given choice, and how they want to be given choice and how often they want to be given choice. And the fact that we don't have a lot of data on this contributes to a lot of variability in IRB decisions, which then just leads to more complications. So people are doing research trying to figure out what is it that patients want, but patients, as we know, the average person doesn't have a really great understanding of how research works. And so there's a lot of education that needs to be done to help people understand what it is that they really want. But this is a new and exciting area of potential empirical research that can inform how we better inform and respect research participants. So very briefly, and hopefully then we can have some time for questions or comments, I want to just pivot a little bit and talk specifically about some of these challenges and considerations in the context of dissemination and implementation research, which is very similar and shares a lot of characteristics with pragmatic clinical trials when it comes to these ethical considerations. So the key features or a definition of dissemination and implementation research is the systematic study of methods to promote integration of research evidence and evidence-based practices into routine healthcare and community settings. So while PCTs generally involve that sort of head-to-head comparison of different kinds of interventions to inform practical decision-making, D&I research really aims to, how do we get people to use the stuff that we know works, right? How do we get those interventions to reach, those proven, tested, evidence-based interventions to reach all patients in their routine care? And again, this is really about bridging that gap between discovery and practice. And often D&I research uses designs that we see in pragmatic clinical trials. I thought it was probably worth parsing out dissemination, which would be studies on how to best reach stakeholders and spread knowledge, versus implementation, which are most of the studies, a lot of the studies that we see, studies on how to adopt, integrate, and sustain evidence-based practices within specific settings, either by changing practice patterns or overcoming organizational barriers. A lot of the same ethical considerations as PCTs or ethical, unresolved ethical questions. This question of, is it human subjects research, and who is a subject and who should provide informed consent? Again, due to the integration of the research with practice and the use of proven interventions. I'll talk about this in a minute. Dissemination and implementation research raises some concerns about equipoise or uncertainty, right? So in a randomized controlled trial, a condition of doing the research is that there has to be true uncertainty in the medical community about which treatment is better, or whether or not the treatment that's going to be tested is better than nothing. In the setting of D&I research, I think the question that often comes up is, like, what are we doing randomizing people to see if something works? If we know this works, shouldn't we be trying to give it to everyone? And that creates some challenges for thinking about randomization and design and delivery. And I think one of the big challenges, again, is how can we maintain scientific rigor given that we're in routine care settings? There's a lot of variables that are impossible to control, and things change over time. So how do we make sure that we can really trust the data that we're collecting? How do we make sure that it's trustworthy when there's so many different moving parts and we're unable to control the environment? That's sort of why we're doing the research in the first place. I just wanted to provide some examples here, both to give you more examples of D&I research, but also get you thinking about some of these questions. So I just want everybody, it's hard to do anything interactive online. So I just want everybody to think for a minute about these three different studies. So the Quartet study was a trial that randomized participants with hypertension to either receive a quad pill, which was like a 4-in-1 pill, or regular therapy. Oh, I also see I have another typo. Fingers faster than my mind. So they either got the quad pill or usual care. And then their blood pressure data were collected and analyzed to determine whether this quad pill was better than usual care. We all know that sometimes it's easier to take one pill than 4 pills. The Kaiser Permanente Northern California Hypertension Program was a study that involved over 300,000 participants with hypertension system-wide. It involved several different program components, such as a hypertension registry, clinical level performance feedback. So providers got immediate feedback on how they were doing in terms of adherence to practice guidelines. Patients got medical assistance visits for blood pressure management in the home. And again, the single pill combination therapy was implemented. And the primary outcome was changes in rates of hypertension control, heart attacks, and fatal strokes. And then a third study, acute coronary syndrome quality improvement. This involved 21,000 patients across 63 hospitals in India. It used a cluster randomized step wedge trial designed to compare a tailored intervention that included provider training and access to tools for behavior change versus usual care. And the primary outcome was major adverse cardiovascular events at 30 days post-discharge. So just think for a second, was each one of these, would you say that this is human subjects research? Does this meet the federal definition of human subjects research? Does it require IRB review? Might it require consent for patients? What would you think, just looking at sort of who's involved, how the study is designed, and what the primary outcome measures are? I know that's not a ton of information, but I'm just using this as an example to show diversity in decisions across different types of studies that seem fairly similar. So the quartet study, I should disclose that I was on the DSMB of the study. It's now has multiple publications out there. That was determined to be human subjects research, and it underwent IRB review. The Kaiser Permanente study was classified as quality improvement. It did not undergo IRB review, and the acute coronary syndrome quality improvement study in India required IRB approval from multiple IRBs and ethics boards, even though a lot of these have the same interventions and they're using the same outcome measures. So it's important to think about, to think more about this. And I think the punchline is always talk to your IRB. You don't get to decide whether something is subject to IRB review or not, or whether or not it's quality improvement. And this is an ongoing, an ongoing debate in the research community of what kind of oversight is needed for quality improvement when we do decide that it's exempt from IRB review. Again, I think this question, similar question that we see in pragmatic clinical trials: who are the participants and who needs to provide consent? This is just an example of one type of dissemination implementation study. This is a study in Nigeria that blends strategies both from the Kaiser Hypertension Program intervention and the World Health Organization HEART, their HEART's guidelines for healthy lifestyle counseling. The intervention involved strategies at the patient, clinician, and systems level, so evidence-based treatment protocols, access to essential medicines, risk-based disease management, team-based care, monitoring systems. And I think that reasonable people might disagree about whether or not it's necessary to obtain informed consent from all the patients who receive care at the participating health centers and from all the clinicians who provide care at participating research sites to implement this multi-level bundle. That's going to be made, that the impact of which is going to be assessed through some, one or two primary outcomes that can be pulled from the electronic medical record. This is just sort of a comparison to those other studies. This is based on an article written by one of the investigators from the quartet studies, looking at differences and sort of addressing some of the differences across institutions and across studies about decisions about whether something, who is a participant, who needs to provide consent, can consent be waived. A lot of these things look similar, but different decisions have been made, calling into question sort of the need just to tease out some of these issues in your thinking and make a case for what you're going to do. And then lastly, I just wanted to address this issue of equipoise, right? Is there uncertainty? What can we do? Is it ethical to randomize? That's the big question, right? In order for it to be ethical to randomize people, we have to have uncertainty or equipoise. So the IPREX trial was the trial that tested PrEP, pre-exposure prophylaxis for the prevention of HIV transmission, tested PrEP against placebo. Prior to the trial, there was genuine uncertainty whether or not PrEP had any effect on rates of HIV transmission. That trial established the efficacy of PrEP. Once that efficacy was established, it was important to do research to try to figure out how we could get more PrEP into the hands of patients who needed it, right? So this trial was aimed at increasing PrEP prescriptions and testing two different implementation strategies, right? A coordinator who would be responsible for managing the prescriptions and distribution of prep for anyone who was eligible for it and who could benefit from it, based on criteria, and an adapted web-based management tool. That didn't involve, interacting with a human about this. And there was limited evidence on both, and there might be variability in success due to context or study population. Some people might like dealing with a person, and some people might like the anonymity of a web-based tool. The solution in this case was a step wedge design that randomized clinics across time to different these different implementation strategies, ultimately determining, providing more data to determine which strategies worked for different people. But there's discomfort about what to do if you think something works, and whether or not that can be withheld from participants, even when they might not be getting it through usual care. And that's something that has to really be thought about in developing these kinds of studies. So key takeaways, quickly, methodological choices have ethical implications. Standard ethical frameworks and regulatory frameworks were developed with RCTs in mind. This doesn't mean that RCTs are more ethical or safer or more risky. It just means that RCTs are more straightforward to present, and that's the model for how we think about respect for persons, beneficence, and justice. New methods have emerged to address the real world shortcomings of RCTs, but designs and approaches like pragmatic clinical trials and dissemination implementation research introduced unresolved ethical and regulatory concerns. It doesn't mean that they have more ethical problems. It means that these types of studies might be challenging for submission, review, and approval, even though they are not inherently riskier. And I was shocked when I decided that I wanted to talk about ethical issues in PCT and D&I, in the total lack of scholarship and ethics and guidance on these issues. Most of it is coming out of that NIH PCT collaboratory, with fewer people having written about dissemination and implementation studies. But better understanding, I hope, of the ethical contours of these kinds of research can help you consider challenges and propose solutions as we wait for consensus and guidelines. But having a better understanding of these issues should hopefully lead to better protection of participants and can minimize roadblocks to IRB approval. So I'm going to stop sharing. And I have a couple minutes for comments or questions. I hope that some of you, I hope there's a mix of people who are kind of new to these kinds of approaches and designs, and maybe people who are involved in this kind of research and kind of puzzling on was it so hard to get this through IRB review when we're just testing the treatments for which treatments or interventions for which there's already evidence that they're safe and effective. Okay, well, I'm not hearing anything or seeing anything, so I'll put another plug in for everyone to take advantage of the services that are offered by the Center for Clinical and Translational Science, not just our regulatory and ethics consult services, but our statistical, our biostat services, our recruitment services, our community engagement services, all of the educational programs that we offer, and our wonderful staff who are there to help you navigate all of the different challenges that arise in research across the different designs. So thank you.
Thank you, Dr. Anderson, for this wonderful presentation. And thank you, everyone who attended today. The next best practice hour will be on Tuesday, 21st July from noon to 1 p.m. Please keep an eye out for emails. Thank you so much.
Thank you.